Welcome to Clinical Convos, a show that provides bottom line answers to key stroke recovery questions. I am your host, Henry Hoffman, an occupational therapist and co-founder of Saebo, a leading provider of stroke rehabilitation products. If you are a health professional, patient, or caregiver and want to get to the bottom line regarding effective treatment options, then you have come to the right place. Today, we are going to dive in and discuss shoulder subluxation, which is a common condition that affects many clients with brain injury. To get to the bottom line regarding this topic, I'm excited to bring back Dr. Steve Wolf. As many of you know, Dr. Wolf is a physical therapist, a clinician, and a neuroscientist who has co-authored hundreds of research articles. He is basically a pioneer in the stroke rehab research world, folks. Dr. Wolf received his PT training at Columbia and Boston University and his doctoral training at Emory University, where he is a professor in several departments. Sir Steve Wolf, thanks for joining me again on Clinical Convos. How are you?
Fine, happy to be back.
Yeah, it's good to have you back. I'm excited to discuss a topic on the shoulder. It's a love-hate relationship for me because I love treating the shoulder joint. It's one of my favorite joints to treat, but it is a nemesis for many stroke survivors. So are you ready to dive in?
Let's go.
All right. Since our audience is made up of clinicians, patients, caregivers, let's just start off with discussing the basics. What exactly is shoulder subluxation, and how do some of the individuals suffering from brain injury and stroke develop it?
Okay, well, if we can just simply visualize a ball in a socket, there's some parallels between the shoulder joint and the hip joint, but let's just concentrate on this notion that this bone in your arm that goes all the way up to your shoulder and is covered by another bone. That's where that ball is. And the bone you feel on top of your shoulder, the undersurface of it is a socket that receives that ball. Allows us to do a lot of movements in a lot of different directions with our shoulder. And we've got to use it regularly. Unfortunately, what happens sometimes after a stroke is depending upon a lot of factors that we don't really know for sure, in a relatively short period of time or a little bit longer period of time, if we don't move the shoulder joint voluntarily, or we can't, the ligaments that surround the joint and the capsule that encloses the joint start to get stretched because we have nothing to help bring that shoulder back into place and keep it there. So gravity will help separate it some. And with that, everything surrounding gets stretched. Problem is that within those tissues, there are a lot of pain receptors. And so it is sometimes very common, soon after a stroke in some individuals, and shortly thereafter, maybe within a week or so in others, to start thinking about the sense of pain that they feel in their shoulder when it's simply trying to move this hemiparetic joint just a little tiny bit. And some people have a difficult time showing a lot of voluntary movement to begin with. So as a result, even small amounts of motion feel painful because these tissues have been stretched. So what do? We want to move it even less. And it gets more stretched and more restricted in our voluntary control of that. And that even makes it more difficult. The factors that contribute to that, no one knows them all. Some of them could be genetically predisposed. That is, our tissues are very loose. And when we don't move the muscles and those tissues and the joint itself, they tend to be elongated, stretched. And sometimes even those tissues get caught in the joint if one tries to move that joint, even voluntarily or with help. Sometimes refer to that as impingement. Less movement also produces swelling. So the possibility of blocking nerves or tissue in the joint, swelling, the pain associated with that, the weakness from not using our muscles makes it even more difficult for us to initiate and do more movements. So all of those factors come together to cause a joint that becomes less and less mobile. And because of these factors, we might be more inclined not to want to use it. So the result of this separation between the head of this ball on this bone and the socket in which it sits is called subluxation. When that distance between the top of that ball and the roof it sits in starts to get just a little bit separated, That's the beginning of subluxation. And most clinicians, and maybe even yourselves or your family members, can actually sometimes even feel that ball, the top of that ball, which we're not supposed to be able to do very easily. And that's a clear feeling sign of what this notion of subluxation is.
And I believe you mentioned in one of your articles that subluxation can set in as early as 3 weeks. Is that true?
Yeah, yeah.
So
and it varies, but the important thing is, what we must think of as clinicians, is for our patients, especially those who show very little movement early on, that's
Right.
a potential warning sign for this subluxation to occur. So
Right.
early engagement and activation, move, getting that joint motion is so terribly important to trying to minimize the adverse effects, the bad effects that can happen when this ball starts to separate from its socket.
Yeah, so I think that's a great description for the audience. And I know with the scapula, sometimes the scapulothoracic junction plays into this. You think about your rhomboids, and this is more for the clinicians to understand. Patients and caregivers can Google some of these words. But when you think of the rhomboids, the serratus anterior and the upper trapezius, when those muscles get weak, you have downward rotation of the scapula. Traditional theorists used to think that once the glenoid is misaligned, the humeral head falls below it, that locking mechanism is no longer available to the client or the patient, and that could cause some of this instability as well. Newer information, newer data suggests that there's no relationship between scapula malalignment and subluxation. So it is mixed results as far as research at this point. So I think it's important to think about the glenohumeral muscles, but of course also think about the scapulothoracic muscles. But switching gears, many patients listening today are probably wondering if they can actually improve once they have a subluxation. Can they actually improve? And if so, how? Now, obviously, with my 20 years of treating neuro, my toolbox was taping, bracing, E-stim. We're throwing everything at these folks. Of course, if they had active movement, we would do active strengthening. But over the years, I've dialed back some of the things like slings and taping and bracing for reducing subluxation, not for pain, because I know the research does show that it can, minimize pain, taping, if you will. But as far as your toolbox, what do you recommend when someone suffers a stroke and has subluxation now?
Sure. So a lot of information there, and in a way, it's kind of linked to the very last thing that you mentioned, Henry, which may come as a surprise or a source of confusion to some of our patients and their families. There's a lot that goes on around the shoulder. It's not just this ball and socket. There's your shoulder blade. You sometimes feel it. That's called the scapula. And there are muscles that are attached between that shoulder blade and into the shoulder joint itself. So this movement of your shoulder joint, your shoulder blade, which you sometimes can feel on your other arm or have someone do it for you. As you move your arm, you can feel that that flat bone move out to the side and come back. It actually moves in many different directions. So the important point here is to know that there are many muscles that are involved in trying to control that joint. And so one of the things that we advocate for is to keep that entire complex, that shoulder blade and the shoulder, loose and relaxed. You don't want these muscles getting swollen. You don't want them getting tight. You don't want to get them restricted in motion. So one thing that can be done, which is relatively new, is to mobilize, to move the scapula. And that can be gently with clinicians in an effort to realign, maybe even stretch some of the muscles about the shoulder joint and the shoulder blade that get tight, so that when we do other modalities we'll talk about in just a moment, the mobility of those muscles is there. They haven't gotten shortened or over elongated, and can be optimally used when we do voluntary activities connected to modalities, which gets now to the question that Henry has raised. I think it's still very appropriate and proper to think in terms of making those muscles contract. We need to get these muscles to be active. And the ways in which one can do is for the therapist to tell you that you're moving the muscles more or less, but we can help them. And the way we can help them is through electrical stimulation. What does that mean? It means putting electrodes on the skin at specific points that we'll talk about in a moment, shoulder, and I'm talking primarily to patients and their care partners, so that we can, upon stimulation, cause the muscles that should be contracting and working voluntarily every time we want to make our ball stay in its socket. So they contract for defined shortened periods of time, and then they relax to simulate, to pretend to do the very thing that we want to try to do voluntarily. Part of the issue is if this functional electrical stimulation, also called FES, is important or valuable. It's what's the best way to do it. And I'm not quite sure we have a best way. There are several ways in which one can look at providing this stimulation. And there are muscles about the shoulder. And sometimes if you just feel around your shoulder joint, you can feel some muscles. And sometimes when you move your shoulder out to your elbow out to the side and put your hand there, you can feel some of those muscles pop up. It's called the deltoid muscles. We call it deltoid because there are three of them. You put them together, kind of looks like a delta. And so these muscles, particularly the one in the middle and the one behind, have been very important in trying to move the head of this bone, the humerus, into its appropriate location. Other people take the anterior deltoid muscle, and sometimes the supraspinatus, a muscle on top of the collarbone, and stimulate those together. What's the right way to do it under what circumstance? It really depends upon the directionality and the kind of subluxation. Not to make matters more confusing, but the head of this ball just doesn't drop. It can drop and be stretched in a certain direction. Which direction, sometimes we can't tell, we don't know. But what's important is to try to determine which direction that motion has occurred, because that will help inform us which muscle pairs do we want to stimulate to redirect that ball back into its socket in the most appropriate manner.
Yeah, that is.
Now, it's not just the passive idea of here's the stimulator, it's going to stimulate muscles, everything's going to be fine. It's a nice start, but that has to be complemented with voluntary efforts to try to help that stimulation put those muscles back into place.
Right,
so a good idea is to combine voluntary movement in synchrony to when one feels the stimulation.
Okay, that was very good. So let's unpack that, because there's a lot of stuff there that's worth talking about. First, you brought up caregiver, patient trying to palpate. It's amazing when I tell my patients, just put your finger where that little divot is, and then go to raise your arm, activate your arm, do anything, reach forward, and suddenly you can no longer feel the space. And they're amazed by that because they didn't realize how easily one can actually reduce their subluxation. If they do this repeatedly throughout the day, that's going to help, because as you brought up, when those non-inert structures, the tendon, the muscle, the capsule, when everything starts to stretch, like you said, starting 3 weeks post-stroke, imagine if you're an outpatient and now you're 6 months, 7 months, you're chronic, and you're still at a 1-inch, 2-inch space. You then have to somehow figure out, how can I raise it back up? It's called proximal migration. How can I actually get the humeral head to go back up into the glenoid fossa? And so we're not going to do that through weight bearing. We're not going to do that through stretching. We're not going to do that through just imagining. There's other types of therapies out there for stroke recovery. We're not going to do that through passive range of motion. The only way is if you strengthen those proximal dynamic stabilizers. You brought up deltoids. Of course, deltoids are the strongest proximal stabilizers, migrators. Research does show that. And traditionally, therapists would do posterior deltoid and supraspinatus, and they've done that forever. And I do question, why were those two muscles chosen? I'm sure back in the day, there were some studies done, EMG studies that showed, and they looked at arthrokinematics and biomechanics. But the problem I have with the traditional electrode placements, I saw a couple things, and I want to get your input. The first is the supraspinatus is hidden underneath the upper trapezius. So to actually put an electrode over the upper trapezius to get the supra is very difficult. And then you're trying to isolate that. By the way, the supra is tiny, tiny muscle that's a compressor. A lot of these subluxations, you want to go up, not so much in. So then that's a biomechanical challenge. One of the biggest reasons also is the research shows through percutaneous studies that half of your stroke survivors have asymptomatic tears of their supra or other cuff muscles. So imagine you have a cuff tear, a partial tear, and you start stimming that cuff tear. Aren't you going to make it worse? That's a question mark for me. And then the cadaveric studies that you look at show that supra is not even a strong proximal migrator. It's one of the last. And actually the ones that were the strongest were, which you pointed out, middle deltoid, posterior deltoid. Now, if I can geek out, permission to geek out for a second, Dr. Wolf?
Yeah.
Okay. So we used to do a special test for bursitis. It's called the inferior pole test. It's an extra test. So if an athlete or orthopedic patient comes in with C5 dermatome pain, we would resist elbow extension because we're activating our triceps. And what happens is when you activate your triceps, the humeral head will go up and it compresses the bursa. So if I resist elbow extension, I have C5 dermatome pain when that happens. And then I do an inferior pull. So now I'm pulling down the humerus and I resist elbow extension and there's no pain. What that told me was that's a positive sign for bursitis because I pulled down and did resistive elbow extension. That's how strong the long-headed triceps is when you activate it because it inserts on the infraglenoid. So really, I like to do 2 channels. I'll do middle and deltoid for electrode placement, and I'll do long-headed triceps and anterior deltoid because why not? Just to get as much up for proximal migration as possible. Now, if they have some volitional movement all day long, I'm going to recommend activate your own deltoids volitionally instead of using the e-stim. But if they're struggling or if they're very weak, then I'm going to complement that with the stim. So there was a lot there, but I wanted to kind of get your input as we wrap up today's talk.
Very good. There is a lot there. I think the point about the supraspinatus is well taken. It is covered by the most lateral fibers of the upper trap, so it's hard to get a pure supraspinatus activation. And even then, one can question whether it's the most optimal muscle. What's intriguing about the notion of stimulating the long head of triceps in conjunction, say, with the anterior deltoid, is that, remember our anatomy, that long head goes up over the top of the humerus. And so when it contracts, it can actually cause a compression on the humeral head, which is a good thing. Now, it also is an extender of the elbow. So if you're working anterior deltoid with stimulation in conjunction with the long-headed triceps, what you're essentially getting is potentially a flexion at the shoulder joint and an extension at the elbow joint, which is kind of good too, because that in a way that's potentially breaking a synergy, a flexion synergy. So it's a potential win-win situation, as well as dealing with the subluxation. With respect to the issue of tears, I didn't realize the percentage was that high. If they're non-painful, that's fine. And often we don't even recognize when we see a patient or told or informed that there is a tear. So the extent to which we are not compromising the patient's safety or movement capabilities, not exacerbating their pain in the presence of a tear, then to go forward with these stimulation procedures in conjunction with volitional activation is really, really important. Is a primary source. Years ago, when we were doing a lot of EMG feedback, we'd actually monitor muscles with the visual signals from muscle activity and try to uptrain the activation of anterior deltoid, for example, both in a gravity eliminated position, so the scapula is stabilized against the plinth, and then progressively moving towards an independent anti-gravity position. But setting up for EMG and then training people to increase their EMG outputs is time consuming. So it's not necessarily a practical thing to do. But this notion of appropriately determining best electrode placements, it's probably not going to be one size fits all. It really depends upon the nature, directionality, and severity of the subluxation when you capture that in time with the patient. Those are all important considerations.
Yeah, I think so. And I think the take-home message and the bottom line as we wrap up here is I would recommend, in my opinion, start early and often when it comes to right out of the acute, subacute stage, when they're safe to begin therapy. Start the e-stim. If they have active movement, start that volitional movement. Nothing's better than volitional movement if they have it. And if we can strengthen those proximal migrators, it may take some time, it may take months, but we can see a reduction in that space of the shoulder joint. Unfortunately, if you're completely flaccid, that's not going to be an efficacious approach. And you really need, it's almost like the Brunstrom stages. We'll save that one for another talk, but if we can get them out of the flaccid stage, a lot of good things can happen. And it's a tough joint to work with, as I said in the beginning. But I think with the right tools and techniques, patients can do well. So, well, Steve, this has been a fantastic discussion. I really appreciate the time talking about the shoulder subluxation. I know I'm going to have you back for some more popular topics, but any final thoughts as we wrap up?
No, just and one important one, since you mentioned severity of stroke and an inability to do any form of active movement, particularly around the shoulder joint, please consider some form of sling or support. So because we don't have anything going for us now to counteract the mass of this upper extremity, which is now trying to pull this ball away from its socket. So if there's no flaccid, no movement whatsoever, one way of trying to help until such time as there's indication of activation of muscles about the shoulder joint is to support that joint in a sling so that we take away the weight of the limb trying to pull that ball away from its socket.
Absolutely. We need to, if you're 100% flaccid or even just minimally flaccid, we want to de-weight that as much as possible to reduce more issues from occurring, so you can give yourself the best chance for recovery and potentially reduce pain. So good point, well taken. All right, for the folks listening, if you enjoyed this episode or have any comments or experiences you would like to share, please share your comments on any of our social media sites to let us know. Also, if you have any questions for me about our technology and how to obtain a Saebo free trial, feel free to reach out at hoffman@saebo.com. Well, thank you, Steve. Thank you, audience, and hope to see you next time. Have a good one.